morning, everybody. The topic for my presentation is repeat deep anterior lamellar keratoplasty for failed primary deep anterior lamellar keratoplasty. As we all know, deep anterior lamellar keratoplasty these days is the preferred surgical option over penetrating keratoplasties in those cases where the endothelial cell function is good. And hence we have lower rates of endothelial cell loss, graft rejection and failure. Also fewer post-operative complications. Since it's an extraocular procedure, we do not enter the anterior chamber. And also many studies have concluded that the 10 years graft survival of primary DALK is superior to that of penetrating keratoplasty. The indications for DALK in Indian scenario include ectatic corneal disorders, most commonly keratoconus, which account for 70% of cases of DALK being performed in India. Other indications include corneal scarring, corneal dystrophy, infective keratitis, post-ocular surface reconstruction. The causes of failure of DALK include interface haze deposits, vascularization, which account for the most common cause for failed DALKs. The other causes include stromal scarring, recurrence of primary disease, infection, rejection, melt, persistent anterior chamber, post-PRK haze. Most of the study, since there's a rise in the number of cases being performed for DALKs, so there is a rise in the number of failed DALKs, and hence we need a technique to address these cases of failed DALKs. Most of the studies, however, that have been done and reported, they report the results of repeat penetrating keratoplasty following failed DALKs in keratoconus eyes. There are also studies documenting the success of DALK after failed anterior lamellar keratoplasty, but however there's a paucity of studies documenting the role of repeat DALK following primary failed DALKs done for varied etiologies. And to the best of our knowledge, there are just 2 studies published till date documenting the role of re-DALK in cases of primary DALK. These are the 2 studies, one of them published by Sefer Fizi et al. In Cornea. They documented the case of 12 eyes, out of which 11 cases of failed primary DALKs underwent penetrating keratoplasty, and only 1 re-DALK was done. In a study done by Vincent Sorzi et al., which was published in Cornea in 2015, re-DALK was performed in 5 eyes. Both the studies concluded to have an excellent prognosis for repeat keratoplasty. In our study, a retrospective analysis of failed DALK cases were done. 7 patients were included, and re-DALKs were performed 2 months to 6 years after the primary surgery. The follow-up period ranging from 1.5 to 4 years. The indications for primary DALK in our patients included keratoconus with VKC in 2 patients, corneal amyloidosis in 2 cases, advanced keratoconus with heel hydrops with a central corneal scar with VKC in 1 case, and Salzmann nodular keratopathy and interstitial keratitis in 1 case each. The causes of failure noted in our studies included interface haze with vascularization in 3 cases, recurrence of primary disease was found to be there in 2 cases, graft infection with a central deep scar and interface infection in 1 case each. A preoperative assessment was done for all cases, which included uncorrected, best corrected visual acuity, slit lamp examination, IOP, corneal thickness, posterior segment assessment. AIOC2022 was done to determine the donor as well as the residual stromal bed thickness. Now the technique that was used in our study was as follows. First, the host cornea was measured. The donor lenticule of the primary graft was quantified using caliper. The same size trephine was used to mark the host cornea, and the trephination was done to a depth of 90%, following which the superficial stromal layers were removed, and a pneumatic dissection with big bubble technique was performed in 2 cases. This figure, is showing the pneumatic dissection with big bubble, which can be easily performed here, following which the superficial layers are removed and donor corneal lenticule is transplanted. In the remaining 5 cases, the anterior lenticule was just lifted off the bed, dissected and removed. The post-operative treatment included antibiotics, steroids and lubricants. Suture removal was done after 6 months for loose sutures, and remaining suture removed after a stable follow-up period of 1 year. The follow-up in all cases ranged from 1.5 to 4 years. Now the results of our study, the results have been summarized in this table. As we can see, all the BSCVA preoperative in all cases was less than finger counting at 5 meter, and the BSCVA postoperative was better than 6/12 in all cases except one, where the visual acuity was 6/60, since the patient had a central heel hydrop scar. We would like to also conclude that there was no complication encountered during resurgery or follow-up, and at the most recent examination after a period of 18 months after secondary graft, all regrafts were clear, and post-operative refractive astigmatism averaged 2 to 4 diopter. Now I would like to discuss a few cases included in our study. This was a case of keratoconus with VKC, which at 2 years of follow-up developed interface opacification with cholesterol crystals, as is evident in this figure. And since the BSCVA dropped to finger counting at 4 meter, a redalk was performed. This is the immediate post-operative picture. This is the post-operative picture at 12 weeks. The patient had a best corrected visual acuity of 612 and a clear corneal graft, which is evident on the AIOC image as well.
Can you conclude? We are running short of time, you know.
So in conclusion, our study had 7 patients with failure of primary DALK done for varied etiologies, underwent redalk and were followed up over a period of 1.5 years, and we had a successful visual outcome in all patients, and that was comparable to that of primary DALK. Also, we would like to emphasize that the dissection of host bed was easier in the second surgery owing to weaker adhesions, and hence repeat DALK should be preferred in all cases of failed DALKs due to the ease of repeatability, retaining the advantages of primary surgery. And also, as I mentioned, there are weaker adhesions between the stroma and the Descemet's membrane, and the post-operative visual recovery does not differ from that experience after primary DALK. Thank you.